In this section, I'd like to provide some evidence that the need to treat stiffness with manipulation under anesthesia declines with the use of intraoperative verification checks, a decision tree, and self-administered rehabilitation after calipered kinematically aligned total knee arthroplasty. To provide a foundation for this discussion, I'd like to share with you the number of calipered kinematically aligned TKAs that I performed over the last 10 years. We're going to focus on 2018 and 2019 because in 2018 is when we instituted the verification checks and decision tree and stopped formal physical therapy after discharge from the hospital. So in 2018, as I mentioned, we started to use a verification sheet which is based on intraoperative measurements with a caliper of the bone resections, and then their thicknesses are adjusted to match those of the implant after we compensate for the thickness or kerf of the saw blade and cartilage wear. And they are recorded intraoperatively on a verification check sheet. So the distal cuts are recorded, the posterior cuts are recorded, the tibial resection thicknesses are recorded of both compartments, and the AP offset measurements. We then follow a decision tree and adjust either the cut on the tibia, proximal distal, slope, or varus valgus, or we adjust the insert thickness. So there's no going back and recutting the femur, and the decision tree provides, if you will, 2, 3, 4, 5, 6 options. So there's only 6 options to balancing a calipered kinematically aligned total knee arthroplasty, and we'll discuss them during the verification check section in a bit. So if we just summarize the increase in the total number of total knee arthroplasties that I have done in the last 10 years, and then we look at the number of manipulation under anesthesia, and you can see that they're bouncing around from 2010 to 2018 at 12 or so, 13 per year, and the last 2 years it's been 10 over 1,040 total knee replacements. The reason that we did the manipulation usually was not an extension loss but a loss of flexion, which is fairly easily treated, as we'll discuss later.